day, ladies and gentlemen. Hello, dear friends. My name is Vasily Rakhovi. I am the hand transplant patient from Innsbruck, Austria, and the founder of the Voice of ISVCA Patients. Welcome to the interview. This time our guest is Professor Patrik Lassus, the head of the plastic surgery department at Helsinki University Hospital. Under his leadership, the country's first face transplantations were successfully performed in 2016 and 2018, marking significant milestones in the reconstructive surgery in Finland. And let us talk about that today. Good day, Professor Lassus. Nice to see you.
Good day, nice to see you, Vasily.
Professor Lassus, thank you very much for taking the time to talk to me today. It's very nice from you to support our patient initiative with your talk. Professor
Absolutely.
Lassus, in public perception, plastic surgeries are primarily associated with cosmetic procedure, body enhancement, and beauty industry. In your opinion, has the public understanding been changed after performing so highly complex reconstructive surgeries as face transplantations by plastic surgeons? Or it is too early to talk about that? And what motivated you to engage in this field?
That's a really good question, because I think our profession or our field has a image problem, because cosmetic surgery is so big area, and then of course it's really interesting, and people want to talk about those, and you have celebrities having all these cosmetic procedures, so they all think that we just do aesthetic surgery, but I think it's of course I think it depends on different countries, but at least in Finland I have an impression that we've been able to change a little bit of the public perception for plastic surgery within the past maybe 10-15 years, and I think doing these face transplantations or the upper extremity transplantation, then it has helped, because then people see the other part, that we mostly treat cancer patients, trauma patients, patients with severe infection or malformities. So that's I think it's getting better, but it's still, I think the media wants to focus on the aesthetic part. But of course that's a big part of plastic surgery, but it's over represented. But I think it's better than what it used to be.
And what motivated you to engage in this field? In face transplantation?
Yeah, well, I became a plastic surgeon in 2006, and at that time I already knew I want to work with face, because I thought the face is the most important. And at that time there were no one in Finland who was, a plastic surgeon who would only, focus on facial reconstruction. So then I did some extra training with maxillofacial surgery and ENT surgery to, learn more about facial problems. And then, but I had a clear focus on face. And then, of course, they did the first face transplantation in 2005. So we were really excited about that. And then at the time when we started the program in 2011, they done, I think, 8 or 9 face transplantation in the world. So we knew that it's doable and it's possible. So we had these patients that we were not able to treat well with conventional methods. So that was the primary motivation to help those patients, because like for first face transplantation, we had done already closer to 30 different surgeries just to help the patient, but they were not very successful because of the major problems that he had in his face. So that's the motivation. But it's a lot of work. It took us 5 years to build the program, get the license from the government and all those things, and hospital approval and so on. But it's been really, really interesting journey for myself as well.
Thank you. Professor Lassus, when we ordinary people talk about face transplantation, we usually imagine a complete replacement of the face. Is it really so, or are there several types of face transplantation? Maybe you could tell us about that a little bit more.
Like for upper extremity, they're always tailored to the patient, because and maybe it's even more with the face, because every patients that have had a face transplantation, they've had some sort of facial structures left. So the main thing is when we evaluate or a team evaluates a patient for face transplantation, they look at the areas that are missing or injured so badly that they don't function, and then they make the plan. And it can be full face, all the soft tissues, all the muscles, upper and lower jaw, even parts of orbital bones and eyeball has been transplanted. So it can be really, really big, or it can be very small if it's essential, like just mid face with lips and nose and maybe lids. So, but it's always tailored. And I think when we've been, looking at what's been done in the world, and it's when they started, they did smaller. Like the first face transplantation was only lips and nose. But then it's getting bigger and bigger because the field is learning what's possible to do. So then in the beginning they did small ones, and now it's becoming bigger and bigger, or more of those transplantations where you include also bones and teeth and even parts of tongue, because those are the patients that have the biggest problems, who are they are missing upper and lower jaws, or in addition to nose and mimic muscles and so on. So I think the field will see patients with full face, including bones, more in the future, even more.
Prof. Lassus, what type of the face transplantation did you and your colleagues perform? Partial,
Yeah,
combined, or full?
the first one we did was both patients have received upper and lower jaw and parts of tongue. But then the first patient, we didn't include all the skin and muscles. But for the second, we did the full face. So all the lids and forehead and so on, everything was included. But these were because we run a quite big unit, even though Finland is a small country, the healthcare is very centralized. So most of the really severe injuries come to Helsinki from Finland. So we have a large number of patients. So then we, of course, selected the worst patients, the ones with biggest problems for this procedure, and they would be these patients with missing jaws and so on.
Professor Ross, in which cases do patients need face transplantation? You have partially answered my question, but after what diseases or injuries do patients take the decision to undergo the face transplantation?
Yeah, it's. I think the most common indication would be gunshot injury, either self-inflicted or by other person, or some sort of a blast injury, but also burns, very severe burns, where you have like grade 3 or 4, even 4, burn up to the bone. That's one of the indications. But then some malformations, like neurofibromatosis, is quite common. I think there are 9 patients with malformations that are so. But the thing is, in each center, when they evaluate the patients, the major thing is, can it be corrected with conventional methods? Because those are so much lighter and easier, and with less problems and risks. So any patient that can be helped enough with conventional methods is not a candidate for face transplant. So it's really the worst patients with really bad malformations or injuries, deficiencies that are the candidates. And in addition, this is sort of, even though it sounds strange, but you can survive without the face. You can have a tracheostomy and breathe through the neck, and you can have the feeding tube, so you don't have to eat. But the quality of life can be really, really bad.
Yeah.
So that's very important, that the quality of life for the patient has suffered from this injury and deficiency. So that's also very, very important.
And is there any chance of growing facial tissues in labs to make patients less dependent on donorship? And is there any kind of progress in this area of research? Do you know something about that?
It is. It's actually quite. The Society for Tissue Regeneration is actually really older than the Society for Vascular Composite Allotransplantation. So that science has been going on more than 3 decades. and but apparently it's extremely difficult. But there are several groups in the world doing really, really great science, trying to solve these problems, and I know that the achievements are so far is that they can grow cartilage in lab, that it's not immunogenic, so you can put that cartilage to any patient. So that's the first step for patient use. But then the more complex, but I know that there are groups who are trying to regenerate finger, for example, in lab or in these bioreactors. But I would say that, of course, it's hard to predict the future, but it will take some time still. That they are so basic questions that are not yet answered. But I know that there's research going on, and I discussed with Giuseppe Orlando, who is a very prominent scientist in this field, and he said that their goal is that this can, these tissues can be transplanted to patients at before 2050. So that's their goal. So let's hope so, because that would be, of course, the holy grail for
you're right.
people with missing parts.
Professor Lassus, what matters more, patient's reference, or such as skin color or facial shape, or transplant capability? In other words, may patients see the donor face before the surgery and only after that to take the final decision?
No, we don't. It's actually very, very strictly regulated in Finland. This varies between countries, but for Finland, it's the patient, or even I cannot be in contact with the kin of the donor. So there are two separate processes, and they want to keep it so that there's no bias anywhere and no one can influence it, because it's a big gift that the dead person is giving. But I think the biggest obstacle is the number of donors. So because there are many things you have to match between the recipient and the donor, so that you are able to do the transplantation, and the blood type is the first. Of course, it has to be compatible, but also there it goes deeper and deeper with these different antibodies that the patient cannot have against the donor, because if they do, then you increase the risks. So at least in our cases, and in many cases, the patients have had to wait for a very long time. For our hand transplant patient that we did last year, she had to wait 2 years, and that's a very long time to wait, because the phone can ring at any time. So they'll be holding their phone for 2 years. Well, you have the experience, so that can be very, very heavy for the patient. That's the biggest problem. But I think then for the team who makes the decision if the allograft is suitable for the patient, you can't be too picky, because then there are so few donors. So you have to sort of accept the tissues that you are able to transplant. But we do have some rules for, at least for face, we have, so that we would only transplant a male face to a male patient, or a female face to a female patient. That's because of potential psychological effects that it might create. So we think that is too big risk, even though it would be possible to do, and it has been done for extremities. Skin color is not so big issue, but of course Finland is a very homogeneous country. But there are interesting reports from India that they have transplanted a different skin color hands for a patient, but the color changed. So the patients, and they changed within 1 year to very close to the patient's own color, skin color, and that's really interesting. I don't know. I don't think anybody knows what how the reaction happened, but it's an interesting thing to study. So basically, maybe the skin color is not such a big issue. But that, of course, we don't know yet. One problem is size. If the patient and the donor are very different size, but I think those are technical questions that can be solved. So that it's not we would accept it very different size. We just have to make maybe some compromises, but it's possible. But I think the number of donors, but then that's for any, even the same solid organs, kidneys, hearts, lungs. That's the problem. So those patients are, of course, if they don't get the transplant, then they might die.
Yeah.
Our patients can wait, even though it's very, very mentally heavy.
Yeah. And do the face transplant patient need some kind of psychological support before they look at themselves for the first time in the mirror?
Well, in our process we have 1 year waiting period. So when we first see the patient and when we first discuss about transplantation, then we tell the patients that it's at minimum 1 year of project before we can say that we proceed with the transplantation or not. And they see our psychologist and psychiatrist, and also they might see this neuropsychologist, because if they have like a blast injury in the face, it might have affected their brain. So that's one thing we study. So they go this structured protocol through. So we try to check their mental status, if they had depression or anxiety, but most importantly, our psychologists, they want to know if the patient is compliant, because that's very, very important that they go for the rehabilitation and take the immunosuppression drugs, because that's crucial for the survival of the graft and patient.
And would be communication with other face transplant patient helpful in this process, in your opinion?
I think it is, but it depends on the patient. Like our 2 face transplant patients, they said from the very early that they want to stay anonymous. They don't want, and so we've kept their identity hidden all the time. And also, and we then asked the media in Finland that these patients, they don't want to be in the media. So please respect our wish or their wish, and they have respected. So they have been totally anonymous. And I asked them if they want to see each other or meet each other, and they said both no. They didn't want to, but they have their own social networks and friends and families and so on. So, but that's very interesting. But then on the other hand, our hand transplant patient Arja, I don't know if you have been in contact with Arja, the patient we did hand transplantation in Finland.
On LinkedIn.
Okay. Yeah, she's very active, very open, a lot of social media, and she wants to, tell her story and help other people with similar issues. So that's and she was in contact with many patients before the transplantation, and I think she had a friend from India who had double hand transplantation, and they were in close contact. So it depends on the patient, but we do offer that if they wish. But now I think the VCA patient community is quite active. So there are channels, and well, you know much more about this than I do. But that's a very, very good. But it's not also for other rare diseases or even common diseases that patients get support from other people with the same condition and so on. And that's very, very, very helpful, of course.
Professor Lassus, it would be very interesting to know what are the most typical signs of the face rejection. How does it look like, and what causes them, and can the patient to recognize or identify this signs in himself or not?
Well, very interestingly, neither of our 2 patients, the other one now more than 10 years and the other one 8 years, they have had no rejections. Zero. So but then they had our upper extremity transplantation patient. She had a rejection about 6 months. No, it was closer, maybe 4 months after the transplantation. So, but of course, it's they would recognize it themselves from the rash or color of the skin or some sensation if the sensation has recovered well. For the upper hand transplantation patient, there was these small red papules that were not typical. So then, but very, very luckily, we haven't seen any very, very heavy acute rejections. So I haven't myself seen a patient with severe rejection. luckily, and hopefully I won't. But of course, that's a very big plus. And as you know, the rejection can come at any time, even 20 years after transplantation.
Yeah.
Well, I think probably I would say, of course, there is no very clear data, but probably a very common cause, at least, can be said is that the patient's compliance is not perfect. So if you drop out the medication, you don't take the pills regularly, then you increase risk. But then there are unfortunate situations where the patients have got, for example, a severe infection or some sort of malignancy. So then you have to change the immunosuppression. That's always a risky moment when you change something that's working. So then it might lead to the rejection, and then you have a problem if you have an infection and rejection. So how do you treat it? And that can be very, very complicated. Well, I'm a surgeon, so very straightforward person, and I operate people. But then the immunologist would deal with these, and of course it's basically the same thing as with any transplantation, solid organ transplantation. So it's not that uncommon, and they are used to it. Unfortunately, these immunosuppressive drugs, they do increase the risk for infections and some malignancies. So that's but then I think then they've said interesting that cold might be a factor for a risk factor for rejection. But we live in Finland, and it can be very cold, and neither of our face transplant patients have had any rejections. So it's not clear, but it can be that it's more in the upper extremity. I don't know if is that the real view from your window, or there's a lot of snow so it can be cold there as well.
Yeah, very interesting, very interesting. I haven't ever heard about that. Yeah.
There is some reports that patients without gloves, and then very soon after that they could rejection. So that's at least it could be possible.
Understand, yeah. Prof, but if you have to take a biopsy, do you have biopsy? Do you take biopsy on from the transplanted face, from that piece of that part of face, or not? If you have to take.
Yes, we do. Both patients, my patients, they have had these rashes, these different skin conditions. So we always biopsy them if we see something abnormal, or from the mouth, inside the mouth as well. But of course, we all get different skin happenings, like different rashes. So, but we always biopsy them. We did put this, we call them sentinel flaps. So we took some other part from the donor that we transplanted for, rejection monitoring. But I'm not sure how useful that is. There are some reports that it can be a rejection in the face and not in the other transplanted part, or it can be a rejection in the other transplanted part and not in the face. So that's something, because of course if you start take a lot of biopsies from the face, you end up having a lot of scars. But it's that's no can do. But you have to, of course, be very careful, and always if the patient says that there's something not normal, or there's a rash on mine, then I would always biopsy it.
Are there new methods of to predict or to identify rejection without biopsy? I mean, some kind of blood test, non-invasive thermal monitoring, or something else. Have you heard about that? Something?
I've heard about those, but I don't think any of them is yet in clinical use. I think some teams are using. They did in the Boston group. They did, but of course it's in Yale, so I don't know. But that would be, of course, it's very difficult to. But of course, if you would have some non-invasive monitoring system that you see that there is increased blood flow or whatever, then that would be really helpful. But I don't think it's yet proven so that it could be in clinical use. But probably one day. But I think maybe this research is now focusing a bit more on the chronic rejection, and this because that's something that is different from acute rejection.
Yeah.
Comes later, or can come earlier as well, but it's sort of different mechanism, and if it starts to happen, then there is not, it's very limited what you can do to stop it or heal it.
As far as I know, the hand transplant patients have phantom pains before and after the hand transplantation. And how does it look like with face transplant patients? Do they also experience phantom pains or not?
That's interesting thing, because people don't get phantom pain in their face. Or I haven't seen it, and I've been treating patients. Of course, it probably is possible, but I don't remember a patient from my career that would have phantom pain. But I think it's because the nervous system is different in the face. The sensory nerve comes from this trigeminal nerve, which have 3 branches, and if they get chronic pain, it's different than with the hand, with the extremities. Different type of problem. So I think it's probably related to the anatomy or the physiology of the nerves. So they don't have that. Interestingly, for the second patient that we did a lot of work with to connect all the nerves that we could do, and the patient has normal sensation on his face. So he has 2-point discrimination, less than 10 millimeters everywhere. He said it feels like his own face. He can feel cold and warm. Whereas for the first patient, we were not so aware of this. So we did only a couple of nerves, and he has only a protective sensation. So he can feel it, but it's not exact. If we touch his lip, his might be, could be cheek, but he feels it. And actually the most important part for sensation in face is lips.
Yeah.
Because you need that for eating and drinking and speaking. So that affects. And I've actually learned with this face transplant patient, I personally learned that how important sensation is.
Yeah. As I said, fingertips on the hand, yes, lips.
Yes.
Yeah.
Yes.
Professor Lassus, you have already answered my questions at the beginning of our talk, but I would like to ask you once again, so to say, to get the more complete answer. What was your main goal and your colleagues when you started the face transplant program in Finland? Was it only about physical appearance restoration, or does it go beyond that? I mean, recovery of the self-identity, return to the social life. How do you see that?
Yeah. I think, of course, I would say that if you go through your motivations for doing things, I think one thing is that I noticed that, or we noticed that this is a field of medicine that we can, participate in developing, because it's so new, and we understood that we have the infrastructure and the knowledge one day to do it. So that was, we wanted to, because this is at the university hospitals, we do a lot of research science all the time, and we saw that this is a place where we can contribute to the science and make it go further. So I think that's one of the basic motivations for us, to do something new, prove it that it works, and then. But of course, I think the main thing was the patients, because we had those patients that we couldn't help, and they were really suffering, and we would do operations with, technically would be successes, but they would not help at all the patient. So I think that was we had the patients, and then we wanted to contribute to the science. So then I think that was those were the two main reasons to start the program. But then of course we have learned a lot during this journey, and I understand more and more about the meaning of the face. Where do we need the face? So it's really there are so many things that we can affect for the patient if things go well. And social aspect is, and of course, even appearance, aesthetic is important, because these patients might look like monsters. And so they would hide themselves at home and not go anywhere. And if they would go somewhere public, everybody would stare at them, and the children point them and so on. So I think even though it's not about making them beautiful, but making them look normal is very, very important aspect or goal for the treatment, and be able for them to integrate socially and so on. But of course, then it's clear that if they can't eat, then if they can eat again with normally, that's very, very. We all know that eating is it's a pleasure and so on, or even the smell. Because they had no smell before the transplantation, and then they could smell something, not normal smell, but they could smell again things. So that's also, but I didn't realize this, or we didn't realize this when we started. So we've sort of learned with them during the journey that
so to say,
all the things
take for granted. Yeah, you mean?
Yeah, exactly. Yeah, exactly. But I have to say that I'm really I really appreciate what you're doing, and I think this is really important. The field is very small. There are very few patients in the world. I calculated, because I am at the moment the president of the International Society for Vascular Composite Transplantation. So I'm trying to build this net, or make the network better than it has been. So I went through all the cases, that has been done, and I found that there are 66, at least to my knowledge, 66 institutions in the world that have done some sort of VCA. If you don't count the uterus transplantation, which is a little bit different. So it's still a very small society, and I think the number of patients is maybe 300 to 400 altogether in the world. And that includes abdominal wall transplants and larynx transplants and all, if you calculate everything. So it's a very, very small, and I think, of course, we've got a lot of media attention because it's sort of media sexy. They want to report and people want to know, but there are very few people who understand still in the world. And I think I believe in this treatment, that we've done good things for our patients. So it's important to share that, that people understand what this is. And it's because like they think plastic surgery is aesthetic surgery, they probably many people have really wrong thoughts about what the face transplant or hand transplant maybe is clearer to understand. But if you don't have hands, then it's very concrete. But I really appreciate what you're doing.
Thank you.
Or let me say, our field appreciates.
Thank you.
Teams as well.
Prof. Lassus, and are you going to continue the face transplant program in your country?
Yes,
or to expand to other types of external organ transplantation?
Yes, we are. Actually, we are going to list the patient for face transplant. Probably this spring, within a couple of months. And we've evaluated altogether 12 patients now in Helsinki, but we have a very strict selection criteria, so that we want to be sure that because the patients, if we fail, it's a big chance that the patient doesn't survive. So we want to be very sure that the patient, especially for compliance, that they are mentally ready for this big challenge and change in their lives. But yes, we are continuing, and now we did the hand, and I know that there is a uterus transplant program in Helsinki and so on. So yes, and I think because building the whole infrastructure for one VCA type is sort of, it's the same, you can multiply it. So we have the knowledge here and now, and in one of the few centers in the world. So it will be a waste not to continue. But we have a lot of surgeons who and other specialists who are very excited about this. So there is a motivation to continue, and I'm not worried at all. My younger colleagues, they want to join and so on. So.
Prof. You are the president of ISVCA, and could you tell us, please, what are the main goals and objectives of the ISVCA?
Well, the main goal is, of course, to help the patients. I said to myself when I started this It's 2 years period, and I started it last summer in Helsinki where we met. And my goal is two goals. The first one is try to increase the network to get, because there are many centers who have not been in touch with ISVCA and even never heard about it. So I want to have them join us. And the other one is to build this global database so that we would have the data from all the patients, because to prove something scientifically, you need a certain number of patients. Otherwise, it's just a case report, and you can't make any conclusions. So if there are now 56 face transplant patients in the world, so if we can have all them the same data from all these, then we can maybe prove something that this drug is better than the other drug, or some sort of other question. So that's, I think, for the development of the field, it's important to collect all the data. So that's like these are my two goals for this 2 years, or the goals for our society to achieve. Let's see how it goes.
Yeah. Prof. Lassus, thank you very much for your time, and I
Thank
wish
you.
you and your patients all the best. And I hope to see you
Yes.
at the next meeting.
Yes, that will be in Taiwan.
Yes, so far away, my God.
I know, I haven't been there either, so it's going to be interesting.
Yeah,
I hope to
you're
see
right.
you. Thank you for inviting me here and doing the work you are doing. It's really important.
Thank you very much. Thank you very much.
Thank you.
Prof. Lassus, have a nice day, and hope to see you soon. Yeah.
Yes. Thank you.
Take
Bye-bye.
care.